Let's jump right into this explainer. We're doing a continuous, rapid review of high-yield solid organ transplantation MCQs. Let's get started.
Question 13. In clinical liver transplantation, a patient develops sudden, massive hepatic necrosis and severe shock 4 days postoperatively. Hepatic artery thrombosis is confirmed. What is the most appropriate definitive management? A. High-dose pulse corticosteroid therapy. B. Immediate systemic anticoagulation with therapeutic heparin alone. C. Urgent relaparotomy and dynamic retransplantation. Or D. Meticulous percutaneous transhepatic biliary drainage.
The answer is C, urgent relaparotomy and dynamic retransplantation. So, unlike our native livers, which actually have dual blood supplies, a transplanted liver relies entirely on the hepatic artery to supply the biliary tree and a massive chunk of the parenchyma. Early acute hepatic artery thrombosis causes catastrophic graft necrosis, fulminant hepatic failure, or severe biliary sepsis. It's really bad news. The crucial point here is that unless surgical revascularization can be achieved immediately, like before tissue necrosis sets in, urgent listing for emergency liver retransplantation is literally the only definitive life-saving option. Your exam pearl. Early HAT equals catastrophic necrosis, and that means you need an urgent retransplant.
Moving right along to question 14. Which parameter is not included in the model for end-stage liver disease, or MELD scoring system utilized to prioritize candidates for liver transplantation? A. Serum bilirubin. B. International Normalized Ratio, or INR. C. Serum creatinine. Or D. Serum albumin.
Correct answer is D, serum albumin. You see, serum albumin is a component of the older child Turco-Pugh classification, but it's not actually part of the objective MELD calculator. The core MELD score relies on 3 highly reproducible lab variables to predict a 3-month mortality risk in cirrhotic patients: serum bilirubin, INR, and serum creatinine. So your high-yield takeaway, Pearl? MELD is an objective 3-month mortality predictor using strictly bilirubin, INR, and creatinine.
Question 15. Basiliximab is an induction immunosuppressive agent frequently administered right in the operating room. What is its exact mechanism of action? A. Depletion of T lymphocytes via complement-mediated lysis. B. Chimeric monoclonal antibody that binds specifically to the alpha subunit of the IL-2 receptor CD25. C. Binding to the CD3 receptor complex to cause T-cell internalizing modulation. Or D. Competitive blockade of the purine metabolic loop.
And the answer is B. It's a chimeric monoclonal antibody binding to the alpha subunit of the IL-2 receptor, CD25. Basically, basiliximab is a non-lymphocyte-depleting targeted antagonist. It binds with incredibly high affinity to the CD25 antigen, which is expressed exclusively on activated T lymphocytes. It completely blocks IL-2 from binding its receptor, and that prevents signal transduction and downstream clonal expansion, all without physically destroying or lysing the baseline T-cell pool. Remember this pearl for the exam. Basiliximab is a non-depleting CD25 antagonist.
Question 16. What is the major dose-limiting adverse effect or toxicity profile characteristically associated with the use of calcineurin inhibitors, specifically tacrolimus and cyclosporin? A. Acute hemorrhagic pancreatitis. B. Interstitial pneumonitis and pulmonary fibrosis. C. Dose-dependent nephrotoxicity, specifically afferent arteriolar vasoconstriction. Or D. Profound irreversible bone marrow suppression.
The answer is C, dose-dependent nephrotoxicity via afferent arteriolar vasoconstriction. This is absolutely the principal dose-limiting side effect for both tacrolimus and cyclosporine. Acutely, it shows up as dose-dependent reversible vasoconstriction of the renal afferent arterioles. That cuts down renal blood flow and drops the glomerular filtration rate right along with it. Long-term high exposure, well, that can translate into irreversible interstitial fibrosis and tubular atrophy. For the boards, you've got to link calcineurin inhibitors directly to afferent arteriolar vasoconstriction nephrotoxicity. That's your pearl.
Let's hit question 17. Post-transplant lymphoproliferative disorder, or PTLD, is a serious neoplastic complication seen in heavily immunosuppressed patients. Which viral pathogen is strongly implicated in the pathogenesis of PTLD? A. Cytomegalovirus CMV. B. Epstein-Barr virus EBV. C. BK polyomavirus. Or D. Hepatitis C virus HCV.
Correct answer is B, Epstein-Barr virus.
PTLD is essentially an uncontrolled proliferation of B lymphocytes, and it's driven heavily by Epstein-Barr virus infection, or reactivation, when T-cell surveillance is depressed. The primary risk is highest when an EBV-negative recipient gets an organ from an EBV-positive donor. Initial therapy always requires reducing maintenance immunosuppression to let the host's native T-cells recover control. The key clinical pearl here: PTLD is EBV-driven, and therapy requires stepping down that immunosuppression.
Question 18. In clinical lung transplantation, what condition serves as the primary clinical manifestation of chronic allograft rejection? A. Acute alveolar hemorrhage syndrome. B. Bronchiolitis obliterans syndrome, BOS. C. Pulmonary arteriovenous malformations. Or D. Mass-like pulmonary hamartomas. The answer is B. Bronchiolitis obliterans syndrome, or BOS. When we talk about chronic rejection in lung transplant recipients, it manifests clinically as BOS. Physiologically, we're looking at a progressive, fixed obstructive airflow limitation. You'll actually see a decline in FEV1 secondary to continuous immune-mediated inflammation and fibroepithelial scarring of the small bronchioles. Your takeaway pearl is straightforward. Chronic lung rejection equals bronchiolitis obliterans syndrome.
Question 19. Which maintenance immunosuppressive medication is uniquely associated with adverse effect profiles that include severe hyperlipidemia, delayed wound healing, and mouth ulcers, but notably lacks nephrotoxicity? A. Cyclosporine. B. Mycophenolate mofetil. C. Sirolimus, also known as rapamycin. Or D. Methylprednisolone.
Answer is C. Sirolimus. Sirolimus is an inhibitor of the mechanistic target of rapamycin, or mTOR. It has this really unique non-nephrotoxic profile, which makes it a super valuable alternative for patients with failing renal function. However, its use is definitely limited by marked hyperlipidemia, profound impairment of surgical wound healing, which can lead to nasty things like fascial dehiscence or lymphocells if it's started too early, and painful oral ulcers. Your exam pearl: sirolimus is an mTOR inhibitor. It's non-nephrotoxic, but it definitely impairs wound healing. Question 20. What viral pathogen is the most frequent cause of opportunistic infection in solid organs transplant recipients, typically presenting with fever, leukopenia, and organ-specific disease like pneumonitis or colitis 1 to 6 months post-transplant? A. Herpes simplex virus 1. B. Cytomegalovirus, CMV. C. Adenovirus. Or D. Respiratory syncytial virus, RSV.
Correct answer is B. Cytomegalovirus. CMV remains the absolute most common and clinically impactful viral opportunistic infection following a solid organ transplant. It typically emerges right during those first few months as induction therapy wanes and maintenance immunosuppression peaks. It can manifest as a systemic CMV syndrome, presenting with fever, atypical lymphocytosis and neutropenia, or as an invasive tissue disease like CMV colitis or pneumonitis. High-yield pearl: CMV is the most frequent 1 to 6 month opportunistic viral infection.
Question 21. A renal transplant recipient is diagnosed with BK virus-associated nephropathy based on a plasma PCR viral load and a graft biopsy. What is the primary initial therapeutic approach to manage this infection? A. Add high-dose intravenous ganciclovir to the regimen. B. Step up maintenance immunosuppression by maximizing tacrolimus targets. C. Reduce the overall intensity of maintenance immunosuppression. Or D. Perform immediate surgical exploration to assess graft patency.
The answer is C. You need to reduce the overall intensity of maintenance immunosuppression. BK poliovirus is an opportunistic pathogen that causes tubulointerstitial nephritis and graft loss in kidney transplant recipients. Because the virus's activation and replication are driven entirely by over-immunosuppression, we honestly don't have highly effective specific antiviral drugs for it. So the cornerstone of management is a controlled, stepwise reduction of maintenance immunosuppression. This just allows the native immune system to wake up and clear the viral load. Pearl to summarize: BK poliovirus nephropathy requires a stepwise reduction of immunosuppression.
Question 22. Which statement is correct regarding the surgical vascular reconstruction sequence typically performed during an orthotopic liver transplantation? A. The hepatic artery is always anastomosed first before handling any venous structures. B. Venous inflow and outflow, meaning the suprahepatic and infrahepatic vena cava and portal vein, are reconstructed and the graft is reperfused before executing the hepatic artery anastomosis. C. The biliary anastomosis must be fully completed before completing any vascular attachments. Or D. The portal vein is tied off completely, forcing the graft to rely solely on systemic arterial blood flow.
Correct answer is B. During a standard orthotopic liver transplantation, minimizing warm ischemia is absolutely critical. The standard sequence dictates completing the vena cava connections for outflow and the portal vein anastomosis for inflow first, followed immediately by flushing and initial graft reperfusion. Then, the microvascular hepatic artery reconstruction is performed, and the biliary reconstruction is saved for last. The sequence pearl you need to memorize: outflow, inflow, reperfusion, artery, then biliary.
Question 23. In modern heart transplantation, what is the upper limit of acceptable cold ischemia time for a donor heart before the risk of primary graft dysfunction increases significantly? A, 4 to 6 hours, B, 12 to 18 hours, C, 24 to 36 hours, or D, 48 to 72 hours?
Answer A, 4 to 6 hours. The myocardium is incredibly sensitive to cold ischemic injury. Kidneys can be safely preserved for 24 to 36 hours, and livers for 8 to 12 hours, but a donor heart has a very short window. It really must be reperfused within 4 to 6 hours of cross-clamping to avoid severe ischemic damage and immediate post-transplant pump failure. Bottom line, exam pearl: the heart-cold ischemia limit is strictly 4 to 6 hours.
Question 24. Which mechanism describes the target action of antithymocyte globulin, or ATG? The answer is B, depletion of circulating T lymphocytes. Antithymocyte globulin is a purified polyclonal IgG fraction containing antibodies directed against a huge array of T cell surface markers. When you infuse it, it drives a rapid, profound, and prolonged depletion of circulating T lymphocytes, and it does this via complement-mediated lysis and splenic phagocytosis. Crucial pearl here: ATG equals profound circulating T lymphocyte depletion.
And finally, question 25. Chronic allograft vasculopathy, or CAV, is the primary long-term limitation to the survival of cardiac transplants. What is the anatomic presentation of this disease? The answer is B, diffuse concentric accelerated intimal hyperplasia affecting the entire length of the coronary arteries. So unlike standard coronary artery disease that causes focal plaques, chronic rejection of a heart graft manifests as widespread diffuse concentric intimal proliferation. This widespread narrowing leads to silent myocardial ischemia because the transplanted heart is denervated. This actually makes retransplantation the only definitive fix. Your final exam pearl: CAV equals diffuse concentric intimal proliferation.